We see you every day. You take care of patients in every situation imaginable. You are good at what you do, but you always strive for better. Your time is valuable. That's why we are giving you Small Bites learning programs. You can learn a lot in a little bit of time, so let's get to it.
Hi, I'm Mary Ann Sanford. I'm the Global Director for Medical Science and Clinical Education for Cardinal Health, and today I'll be talking about VTE prophylaxis in the clinical setting. In this video, I'll showcase the critical role nurses and doctors play in preventing venous thromboembolism, or VTE, and current evidence-based therapeutic measures they employ for VTE prophylaxis. The topics I will be discussing include: what is VTE? How do VTE form, and what are the consequences? What are risk factors for VTE? I'll also review VTE risk assessment, mechanical and pharmacological prophylaxis, recommend VTE prevention guidelines, and patient education. Venous thromboembolism is a condition that occurs when a blood clot forms in a vein. VTE encompasses both deep vein thrombosis, known as DVT, and pulmonary embolism, known as PE. DVT usually occurs in the lower extremities, such as the lower leg, thigh, or pelvis, when a blood clot forms deep in the veins. DVT may also occur in the upper extremities, although to a lesser extent. PE is a serious and life-threatening condition characterized by an obstruction of the pulmonary artery or its branches by a thrombus. The Centers for Disease Control and Prevention estimate that in the United States, 60,000 to 100,000 people annually die of VTE. Medical and surgical patients, long-term care residents, persons with minor surgeries, and long-distance travelers are at increased risk of VTE. When a DVT blocks lower extremity blood flow, a person may experience pain or tenderness of the thigh or calf, edema, skin that feels warm to the touch, and reddish discoloration of the skin. When a PE blocks blood supply to the lungs, the following symptoms may occur: unexplained shortness of breath, tachypnea, chest pain under the rib cage, which may worsen with deep breathing, bradycardia, syncope, coughing with or without blood, feelings of anxiety or dread. In about 25% of people who have a PE, sudden death is the first symptom. When describing the underlying physiology behind a thrombus formation, the function of Virchow's triad is often mentioned. Virchow's triad defines 3 factors that predispose a person to an increased risk of developing a thrombosis. These factors include hypercoagulability of blood, alteration in blood flow in the vessels, vessel wall injury, endothelial damage. Most of the commonly identified risk factors of VTE play a role in at least one of these 3 elements of Virchow's triad. Individuals who are currently or have recently been hospitalized, those that are recovering from surgery, or are being treated for cancer are at an increased risk for VTE. Therefore, an interdisciplinary medical team and cross-functional departments must work together to develop VTE prevention protocols. VTE risk assessment should include using an evidence-based, standardized tool for determining a patient's risk of VTE. Use of such standardized tools facilitates stratification of VTE potential, but also support communication of risk to the patient's care team and help encourage proper implementation of VTE prophylaxis. A validated VTE risk assessment tool is recommended as an integral component of safety protocols for hospitalized patients, especially since the use of formal screening tools has been linked to better matching of preventative strategies to the estimated clot risk. An example of a validated VTE risk assessment tool is the Caprini Risk Score, or CRS. The tool assigns individual risk factors 1 to 5 points, according to the relative risk of their resulting in a thrombotic event. The CRS tool is designed to be used for ongoing evaluation of the patient throughout their hospital stay. Ongoing evaluation captures changes in clinical status over time that may be reflected in a new score and a revised treatment plan. Now let's discuss VTE prophylaxis. There are two main therapeutic approaches, mechanical and pharmacological. Mechanical prophylaxis devices, such as graduated compression stockings, intermittent pneumatic compression devices, and venous foot pumps, aim to prevent venous stasis, thereby reducing thrombus formation risk. Pharmacological methods of VTE prophylaxis are highly effective and may include various drug derivatives, such as anticoagulant or antiplatelet drugs, heparin derivatives, factor Xa inhibitors, vitamin K antagonists, TPA, and aspirin. Some pharmacological modalities may cause challenges with patient adherence due to administration difficulties, side effects, or missing doses due to patient refusal. Combining both mechanical and pharmacologic prophylactic modalities reduce but do not fully eliminate VTE. A critical component of either of these approaches is education for both clinician and patient. When developing best practices for use of VTE prophylactic modalities, decisions should be guided by up-to-date, evidence-based research and recommendations, including guidelines published by professional organizations and articles in peer-reviewed journals. Government agencies and professional associations may be sources of valuable multimedia toolkits that can be used to support educational activities. AORN, the Association of Perioperative Registered Nurses, for example, provides a list of themed guidelines and examples for implementation of mechanical prophylaxis as it applies to perioperative clinical practices. The use of VTE toolkits can also be considered. These toolkits are collections of related information and resources designed to help users develop a plan or organize efforts to follow evidence-based recommendation for VTE prophylaxis to meet evidence-based specific practice standards. These toolkits can be useful in facilities that don't already have VTE prevention protocols in place. We've been discussing the clinician perspective of VTE prevention, but what about the patient's perspective? Surveys have shown that patients and families are interested in learning about VTE symptoms, risk factors, prevention and complications, yet their awareness of VTE associated with hospitalization is low. Education related to VTE prevention may reduce the patient's risk for developing VTE by increasing awareness and promoting compliance with the prescribed prophylactic measures. Both the patient and the patient's caregivers should be provided with verbal and written instructions on prevention of VTE, including, but not limited to the following: common signs and symptoms of VTE, VTE prevention measures, the importance of adhering to the entire duration of prescribed VTE prophylaxis, the importance of seeking medical help, and who to contact if VTE is suspected. In summary, despite the significant health and economic costs of VTE, prophylactic measures are often underused or misapplied, and patient awareness of the risk of VTE associated with hospitalization is low. Nurses and doctors play a pivotal role in implementing mechanical or pharmacologic prophylaxis and in educating patients and their caregivers about the importance of adhering to prophylaxis recommendations.